Yeah. Good morning, friends, again, and thank you very much, Balaji, and I can't adequately thank you all for bearing with me. But I had always been thinking that, it's like, as I said, it's been a journey for 32 years, and because there is a lot of subjectivity involved in dosha, prakriti analysis, or, or even your vikriti, because vikriti is the main thing that we need to determine before we actually step into treatment. So my focus was always to bring in subjectivity. So if anyone's volunteering, we could do a dosha analysis, and also not just dosha analysis. It'll give you a rough estimate of your blood biochemistry, because it's only when the dosha quantification translates into your blood biochemistry that brings in some objectivity into whatever research we did. So that's why, it's an interesting algorithm that I came up with, after researching the fundamental aspects of Vata, Pitta, Kapha, correlating them with electrophysiology, then interleukin chemistry, and then trying to understand the metabolic pathways, cell signaling pathways, and then understanding the rate at which these doshas influence the intracellular chemical reactions, and hence a rough estimate based on Michaelis-Menten's reactions. And I took in all the biochemical models that are already existing to translate the dosha effect into molecular biochemistry, and then come up with your blood biochemistry. This is a rough estimate. It may not be accurate, but till now we got excellent results. So this device gives you the Vata Pitta Kapha fingerprinting. It gives you a VPK proportions of all of the 42 organs, and then the algorithm picks up what foods to eat, what not to eat, what it considers the Ritu Prabhava, the Dina Prabhava also. It takes that also into consideration. It basically identifies the VPK fingerprint of an individual. From their maps, it gives a rough estimate of your blood biochemistry that I already mentioned, but it gives you a certain signs and symptoms that could be ruled out. And then the algorithm picks up the right formulation, the right herb, everyone, like why Momodia carentia didn't show results while Karela is repeatedly used, because it is good for Pitta Kapha individuals, for classification of the Pitta Kapha. If it was a Vata Prameha, if you encounter a Vata Prameha, so there is a Prameha, there's a Madhumeha. What is Prameha is a condition in which there is hyperglycemia, but that is attributed to increased metabolic rate because of Pitta. So Pitta also increased metabolic rate, and because of which the body resets the HbA1c to a higher level, and that's seen in the VADT trial. So we're not considering that, unfortunately. The VADT trial, the body mentions that the veterans, most of them, if not all of them, were feeling good at a HbA1c of 8.5. Anything less than 7 your HbA1c, of course, this is all speculative at this stage, based on the data that we generated. I'm able to say this, but then we have standard bodies coming up with this standard, say, for example, as I mentioned, that the veterans started feeling hypoglycemic when the HbA1c was pushed below 7 in the VADT trial. The same thing happened in the ACCORD trial, ACC-ORD trial, in which when intense glucose lowering strategies were deployed, especially in patients who had ischemic heart disease and concomitant diabetes, below 6.5, 1 in 3 died. That's like very crazy and a very worrisome number. But I can explain the dosha rationale behind, and then it really becomes not only interesting but becomes very essential for us to understand the dosha fingerprinting before we even attempt to give your anti-diabetic medication. So, for example, we just mentioned yesterday that Pitta aggravation will actually cause increased mitochondrial activity. So the question comes, if the mitochondrial activity is increased, why does the blood glucose rise? Very simple. There are mechanisms already explained, like increased ATP, because when glucose burns, you end up with CO2, H2O, and ATP. Increased intracellular ATP is a trigger for production of more glucagon and incretin, and both of which increase your availability of glucose in the blood, so that when there is hyper mitochondrial activity, the body actually gets the glucose, appropriate glucose, every time it needs. So that could be a possible hypothesis for people who had concomitant diabetes and ischemic heart disease to suffer, mortality in a ratio of 1:3, in a proportion of 1:3, when especially they were pushed below 6.5. So that's why the American College of Physicians gives you the guidelines that, you should maintain your blood glucose levels, HbA1c between 7 and 8. Then it really, and that I would say is pitta pramiha, because going by the definition, your diabetes is a condition in which the body is not able to metabolize glucose, and in a vata predominant or pitta predominant state, the body's dependency on glucose is high in vata, and the body's demand for glucose is high in pitta, and hence the body needs more glucose, and hence such patients, such people would need higher blood glucose levels. And that also explains why HbA1c levels rise over age, over time. And we know that according to vata, the first 20 years are kapha dominant, the next 20 pitta, then vata predominance take place. So when there's vata predominance, the body is hyperexcitable, based on the data that we generated, and hence hyperexcitable tissues would need more glucose because energy is used up faster there. So these are specific metabolic considerations that we need to, from what we realize, that have to be deployed in essentially treating patients. So going further down to the case studies that we had, the next slide, maybe I'll also stand there so that I can operate the.
Or you can just say next if you.
Yeah, then I might have to go back and forth, so it'll be better. I'll just use this. Can I take this?
Yeah. 1 second, please.
Sure, no problem. So this is a female, 23-year-old. She suffered ischemic hypoxic encephalopathy, and there are beautiful pictures of CT scans before and after a treatment. So what does VPK? There's going to be very, very outrageous. People might think it is outrageous, but that's what is possible. So this patient was comatose. I choose patients where there's no competition. In end-stage disease, in refractory stage of diseases like refractory diabetes or hypertension, you don't have competition. And that's safe to use. NICE or even NIH will accept your recommendations when you're not in competition, because there are a lot of data that is generated, friends. And I tell you, so for the NICE or ACS or the American associations to come up with guidelines in diabetes, they investigated more than 15 million, not just 15 million, more than 15 million patients were recruited in those studies. That's huge number, huge. If you have those numbers, then the data will be comparable, and then you have a strong case to suggest. If you don't have comparable data, then choose those areas. That's what we have been doing. Choose those areas where the NICE where NICE guidelines or the NIH guidelines or the AHA guidelines end. You start Ayurveda where it ends, where everything else ends. So that's what we did. Case of ischemic. Hypoxic encephalopathy before and after the next please. So the MRI scans before and after. The left is before the patient just started treatment, and 6 months after which it was interesting case. The rostrum was somehow saved during that encephalopathy that she suffered. When. I don't want to go into how she suffered that, but then that was the case that was given to me. She was, we started off early, because in our experiments, what we saw was in animals where we showed regeneration, we had to start early. Early is within the first 7 days. So because we know that reorganization of the tissues happens right on the day 5. So you need to start before the reorganization, remodeling of the tissues starts. So when we started, the effects are to be seen. Very interestingly, this lady who forgot, based on the Kale Kapota Nyaya, right on the day 8, this lady woke up from coma, and after 6 months she started behaving normally, but she was like, she didn't remember anything. Then I said, once we continued to the treatment, and then I explained that because the limbic system was intact and most of the impressions are stored in the limbic system, the associative neurons would develop, and then they'll pull up information from the limbic system. And then after 18 months, this lady completely remembered everything that happened. That's really amazing. After 18 months, she's completely, and she's 32-year-old now, and she's doing extremely well, doing her job, and going ahead with her life. This is vitiligo, friends. This is before, during, and after. This is Crohn's disease, as I mentioned yesterday. Crohn's disease, ulcerative colitis, autoimmune disorders. These were patients who were referred by the GPs, which I already mentioned yesterday, that we work with the GPs. We work when the patient comes to me. I call their GP. I tell them that your patient came to me. Would you want me to work with you? If he agrees, I work. If he doesn't work, I don't work. Because GPs, I tell you, doctors, are people. Doctors are not. They're full of compassion. I tell you, they really struggle when the patient suffers, and so if you work with them, what will happen is, as everyone mentioned, everyone would agree that the problem with the doctors is that they don't want their patients to suffer. But we are not trained on diet. That's what we should understand, that allopathic doctors are not trained on diets, nor on the dosha. So if we work with them, we continuously train them also during our discussions, and then we will be able to, get better results. And now most of the doctors back in India, at least in the 2 Telugu-speaking states, most of the allopathic doctors refer their end-stage patients to me. End-stage are like, when the patient has a primary pulmonary hypertension. I say, no problem. I'll get the RVSP from anywhere from 100 to 120 to 40, 45. That's good enough. That's still high, but that's good enough for a PPH patient. All this ulcerative colitis. I say, if you have any problem with UC or IHT, Crohn's disease, refer to me only if you see a problem, if you need the adjuvant. That's when what happens after 18 months is the pictures on the right show you, those lesions of Crohn's disease completely cured. They do a laparoscopy, and then they see, sorry, not a laparoscopy, colonoscopy, and then they compare the results from the past, and then it is possible that it can be completely cured, completely reversed. That's what we were able to demonstrate in several hundreds of, not just 1 or 2. We're now comparing all the data that we generated in the last 22 years, and then we are trying to do a metadata analysis and then make a case so that we go for a clinical trial. If possible, we'll request the NIH. I've already met the US FDA officials. They're very willing to do a clinical trial. See, what is the problems of the Western world? What are the problems of the Western world? Number one, spending a lot of money on geriatric care, palliative care, hospice. These are the pain points. If we are able to come up with end-stage care, again, if there is a EF, EF is less than 30, and the patient needs a heart transplant. Hearts are not vegetables that are available in the markets, right? You need to wait for the appropriate heart to be HLA compatible heart to be available. So during which time, so we come up with nice guidelines that will fit in our remedies into their protocols, which are not competing. Not because we are less, but because we don't have data. You have data, you demonstrate, they will agree. That's it. That's been my experience, of whatever data I demonstrated, and US FDA immediately waived their fee even for collaboration with us and to do a trial. So it's only that, we need to have that compelling data and then the mechanistic evidence of how it happened. See, just because, we find some associations, it doesn't mean anything, really, friends. We find associations with doshas to some diseases, but that doesn't mean anything until unless we unravel the mechanism. So that's why we have Bhushan ji either here or Rajiv ji. I know all of our doctors would agree that we need university collaborations. We need to do a lot of experiments to essentially unravel the underlying mechanisms. Once you're able to substantiate with underlying mechanisms, there's no way NIH or NICE is going to, oversee your results. That's been my experience, at least, So as I mentioned, the different associations somehow coincidentally were dealing with different dosha constitutions patients. So in a kapha, you essentially go with the guidelines of the endocrinologists. In a pitta kapha, you go with the American Diabetic Associations. In a vata dominant, I mean, it's dosha based recommendations that need to be made. And also, cholesterol. See, cholesterol is again a very, okay, I'll just put up give you a one-liner of, see, with statins, we are actually blocking the beta oxidation of the fatty acids, right? Applying simple principles of chemistry, organic chemistry, and biochemistry, friends. If you're blocking a beta oxidation, won't it be possible for the body to trigger either alpha oxidation or a gamma, omega? If alpha oxidation triggers because of, okay, statins have helped 49% of patients. That's why they're in vogue. That's why they made $17 trillion for those who have dealt with them. But then, sorry, 17 billion? Year on year, that is the profit. For the past, 17 billion year on year for the past 30 years. So several companies. So what happens is when you're giving statins in a patient who, there could always be a alpha or a gamma or omega oxidation. If omega oxidation occurs, you end up with AKI, acute kidney injury. If gamma oxidation occurs, you end up with a liver failure. If alpha oxidation of the fatty acids occur, you end up with a new form of cardiac failure, all of which were reported by the Hunt guideline, the Hunt report, 92,000 patient retrospective analysis of statins. So even, see, what I'm trying to say is, even the side effects of drugs could be explained based on dosha analysis. That's the point I'm trying to drive here. So friends, what I would say is, all of these are algorithmic. After treating 28,000 patients in the past 22 years, 58 patentable technologies developed. We developed an entire algorithm for how to translate this VPK, this subjective knowledge into a objective machine-based algorithm. That's what we tried, and we have come up with this device and working. We are in the process of initiating this clinical trial in India. But man, the last part of integration with the app is left, which is we're working on it. Yeah, I'm just done. So this is there's an entire algorithm. There's a mathematical analysis of how we have arrived at these algorithms, and then based on our own experiments, vata could be proportional to the intracellular sodium chloride and calcium ion concentration, inversely proportional to the potassium and ATP ion concentrations. Oh, you already sent your report?
Yeah.
I just so there are certain vata. Okay, this is just a quick one-liner around vata, pitta, and kapha correlations with different intracellular ionic concentrations, but the vata formula goes into 70 A4 size page document, friends. It's not just, it's not conclusive, I just wanted to give you some idea of how we arrived at, this blood biochemistry from this HRV fingerprinting, and what are the machine learning algorithms that you use? Yeah, it's already. And yeah, so this is going to be interesting slide because, look at what we are doing is we're discussing this point. But this point could be arrived in 3 different mathematical pathways, friends. So if in all the biochemical reactions in the body conform to Le Chatelet's principle. So everything is reversible, essentially. Everything is reversible if you know which path the body took to arrive at a certain point. Broadly, there could be 3 pathways. This is not just this is not even the beginning of machine learning algorithms, but this is the formulae that I use to arrive at the machine learning algorithms and fit into this device and to, help bring in objectivity into whatever I'm doing. So friends, so what I would say is gray areas. Let's concentrate on the gray areas. That's what I would propose on the gray area. What are the gray areas? The functional diseases are gray areas, isn't it? Functional diseases, debilitating diseases, emergencies, let's not get in there. But if there is end-stage patients, aging population, decreased quality of life, or decreased symptom-free survival, yes, that's the area which we are looking into, pitch in Ayurveda and to fit into the modern guidelines. That's what I would say. Because genetic therapy, modern medicine excels excellently well in emergency care. So So there's there's an entire model that I've arrived at, but let me not, okay, what is the benefit? If we are targeting only the end stage population in NHS, in the UK, only the end stage, only the palliative that NHS would allow us to work with, we're going to save $100 billion year on year for the NHS. $256 billion pounds, sorry, would be saved by the NHS in loss of productivity. Now that could be brought back to the GDP. That would be a very strong proposal if we're able to do this. So there are several partners that we're looking for. Creation of talent pool, rightly recognized by you. You said we need to create a new generation of talented through creation of collaboration with universities, and then create the next generation doctors who would be trained both in the modern systems and the Ayurvedic system. So we need to do that. Come up with your own ERP, because ERP and EMR, because if someone was saying yesterday that so many people come to India for treatments, but do we have the entire data of where they are going? What are the treatments they've encountered, and what are the outcomes? We don't have that data. And also if we have data from different institutions, that data will be struck off for not having standardization. So as a data scientist, I can tell you, I'm a data scientist from the University of Texas, Austin. So your data need to be standardized. We need to work on that. We need to create a uniformed EMR for India, if at all. We're working with EMR. Here, the advantage is there. So what I was suggesting, that if we could do a large-scale trial in India under the monitoring of the NHS, I think we'll get numbers in India. Once you have numbers, statistically significant data, then NHS will be compelled. And that's a proposal that I have from friends. There's a roadmap that Ayurveda or a scientific Ayurveda could essentially get into the mainstream in a 10-year pathway if we all work together. Otherwise, I'll keep working for the next 22 years before I die, and then that's all I wanted to share with you. Thank you very much, friends. Really appreciate. Bhamraji, I owe you indebtedly, not I, just because the entire Ayurvedic fraternity would owe you, because I don't think, there was any time a conference where, professionals from the modern medicine and the Ayurvedic fraternity could sit together and discuss about the issues and work together. This is an amazing feat, Bhamraji. Thank you very much. Really appreciate it. All the very best. Thank you very much, everybody.